Congratulations, you've finally made it to the fourth and final lesson on respiratory emergencies. In this lesson, we're going to discuss some of the common respiratory problems and how to manage them. So let's get to it. So let's talk about what happens when our lungs get infected. It's a complex process and there are a lot of different culprits involved. Think about how often we breathe. Our lungs are constantly exposed to the outside world, which means they're vulnerable to all sorts of things that can make us sick. One major category of things that can cause lung infections is bacteria. We've all heard about bacterial infections like pneumonia. These living organisms can multiply and cause damage in the lungs. Viruses are another common cause. They're different from bacteria though. They actually invade our own cells and use them to make more virus cells, and then it spreads all over the place. Think about how long it takes to recover from viral infections like the flu. So it takes a while for our bodies to respond and put up a formative defense to, get us back on the healthy track. Then we have fungi. These are less common, but can still cause serious problems, especially for people with weakened immune systems. They're things like molds and yeasts, and they can thrive in warm, moist environments like our lungs. Protozoa is another type of organism that can cause lung infections. These are a single-celled organism, but they're not bacteria. They're more complex and they can cause some pretty serious infections. And of course, there's other organisms, other things out there, and this is kind of a catch-all category. It can include things like parasites or even just inhaling some kind of irritant that bothers our lungs. So when we talk about infectious diseases, they can cause the tissue and airways to swell up, a lot more mucus to be produced, and sometimes even pus starts to form in the airways. Now when the airways narrow, it makes it a lot harder for air to flow through it. This is where that Postul's law comes into play. The resistance to the airflow increases a lot exponentially as the airway gets smaller. So the smaller the airway, the more inflexible the airway, the more problems are going to result. Also, if the alveoli get filled with fluid or pus, they can no longer do their job. They're no longer part of the gas exchange process, and they may even completely stop working. Pneumonia can be caused by all sorts of different bugs, bacteria, viruses, and fungi out there. Bacterial pneumonia is the most common cause, the Streptococcus pneumonia. The good news is there's actually a vaccine available for this one. So some people are at higher risk of getting pneumonia. These are groups of people like our older adults, those with chronic conditions, smokers, anyone that's having trouble breathing effectively, like our asthmatics and our COPDers, people with lots of secretions, those that have some pulmonary fibrosis and those kinds of things, or those who are immunocompromised, especially those are at risk of pneumocystis pneumonia. We really encourage high-risk patients. Most high-risk patients are encouraged to get the annual pneumonia vaccine in order to protect them from the possibility of getting pneumonia. Of course, there's always the risk of antibiotic-resistant bacteria that can also take up residence in our respiratory tract. These can be pretty dangerous for paramedics, so we need to be extra careful with these when we're exposed to these. Always ask where the bacteria was found before treating the patient. And if the bacteria is in the respiratory tract, make sure you're wearing the right respiratory protection to make sure that you're not risking exposure to that particular bacteria. When assessing a patient with pneumonia, here's what will usually tell you what's going on with them. If they've been feeling weak for several days or for several hours or even days, and they've got a productive cough, that means they're coughing up a bunch of junk and mucus and all that, running a fever, and they may even be experiencing chest pain that gets worse when they cough, and is generally atypical from chest pain that's associated with a cardiac issue. The pain is more associated and caused by the bacteria that's set up shop in their lung, and it's causing discomfort. These infections might come on suddenly, or they could develop gradually over time. Pneumonia is quite often found to be a secondary infection that can follow things like the flu. So when you're doing a physical exam, the patient might look really, really sick or have had a toxic looking appearance to them. Or they might not even be coughing. You might hear crackles when you listen to their chest, or feel more of a vibration or a tactile fremitus and notice more sputum production going on with them. You also may hear some bronchio or bronchiovesicular breath sounds over areas where the lung tissue is consolidated. In more advanced cases, you might notice breath sounds that are diminished or even absent in certain areas of the lungs, or that the sputum might become really thick or really full of pus, really thick and pussy looking. The patient might be in pain when they breathe as well, and you might even hear a pleural friction rub in the area that is affected, by the area that is infected by the infection, or affected by the infection. That's interesting. So pneumonia usually hits the lower parts of the lungs, and it tends to affect just one side. You might notice that their oxygen saturation drops a lot when they lie on that one side. A lot of pneumonia patients end up dehydrated. Supportive care for these patients includes oxygen, managing those secretions, transporting them to the nearest medical facility. Remember, bronchodilators won't help patients with pneumonia itself, but they might make it a little easier for the patient to breathe. And this is going to be especially true with those patients that maybe have some kind of comorbidity going on with them. Maybe they're an asthmatic, or maybe they have COPD. So the bronchodilators may actually help to a small degree, but they're not a huge help with this like we would mistakenly believe that it might be. So the infection is in the upper airways. If the infection is in the upper airways, you might need to take more hands-on approach with the airway management. For infections in the lower airways, it's mostly about giving supportive care and getting the patient to the hospital as quickly as possible. So location is the biggest difference. Upper airways, you're going to be dealing with a lot more coughing and mucus and those kinds of things, and suctioning may need to be involved, and all that. In the lower airways, it's going to be much more supportive, where we're providing oxygen and we're trying to get as much oxygen into the bases or the alveoli portions of those lungs, so that gas exchange can occur effectively. Alveoli are pretty vulnerable and can be affected greatly by several different issues. They can collapse if there's an obstruction in the larger airways from outside pressure. They might fill up with pus, blood, or even fluid, and they can get damaged from things like smoke or toxins. About 79% of the air moving through our lungs is actually nitrogen gas, which helps keep the alveoli open. So if a patient's given 100% oxygen, any alveoli that are blocked can collapse when the oxygen moves out, leading to atelectasis. So it's actually pretty common for some alveoli to collapse here and there, so it's not that unusual of a situation. Things like sighing, coughing, sneezing, or even just changing positions are thought to help open back up those closed alveoli. But when these things don't happen, more and more alveoli can collapse and not open back up, which can lead to an entire lung segment collapsing. And when this happens, there's a much higher chance of pneumonia setting in that particular area. The area that is affected can hold on to the pathogens that are trapped in there, and might lead to all these things, this bacteria growing and causing pneumonia. So make sure to check the sputum that is an unusual color, and make note of that. And also, if the patient has a fever, ask if they've had recent chest pains, abdominal surgery, or something along those lines that can be a clue. Patients that have had abdominal surgery might not be taking as deep of breaths, which would further allow some of those alveoli to collapse and allow pneumonia to set in. After surgery, patients are encouraged to get out of bed, cough, take deep breaths, and do all those kinds of things to keep their lungs clear. They'll also use something called an incentive spirometer, which helps measure how deep some breaths that they're taking. These are all things to assist with staving off the possibility of pneumonia. And this is very common in post-surgical patients. Depending on the surgery, it may make a difference, and depending on the age and some comorbidities and those things like that is when we'll see those being used. Cancer is actually one of the most lung cancer specifically is one of the most common types of cancer out there. It's especially common among people who smoke, clearly, those who have been exposed to lung hazards at work such as asbestos and things like that, and those that are around secondhand smoke. In fact, smoking is responsible for about 80 to 90% of all the new cases of lung cancer. So it's a little food for thought when you think about, the role that smoking plays in lung cancer. Lung cancer often shows up with first with some blood, coughing up some blood, and uncontrollable coughing as well, especially when the tumors start to get larger and begin bleeding. COPD and poor lung function are pretty common in patients with lung cancer as well. So, not only do they have lung cancer, they have some other breathing issues that kind of comes into play as well. And cancer from other parts of the body can often spread and metastasize or find a new home in the lungs, absent there being any history of a lung issue. So it's not uncommon for it to show up. Sometimes cancer from other parts of the body, they'll spread to those lymph nodes in the neck, and then they can start to block the upper airway, which can be a big problem. On top of that, chemotherapy, radiation treatments often come with their own set of pulmonary issues. So we need to keep an eye out for those as well when we come across patients that, relay to us that they're getting chemo or radiation therapy and they're having a new onset of some sort of a lung issue. And either the tumors themselves or the treatments might cause pleural effusions, where fluid starts to build up in the space around the lungs, as a response to, either the tumors or the treatments. Those things may start to show up. When it comes to pleural effusions or hemoptysis, there's not much we can do in the pre-hospital setting. So if they've got a pleural effusion or they're coughing up blood, there's not a whole lot of things that we can do to manage that, to change that, other than getting them to the hospital as quickly as possible. But realize sometimes we're going to be called out for those end-of-life situations where we'll see these kinds of things. What we oftentimes will see is that we'll see some depressed respirations caused by these large doses of narcotics that they're given to manage their discomfort. These patients are almost always on hospice care. So if you do need to administer Narcan, just titrate it just to enough to improve their breathing and don't completely reverse their pain control. It's not very often that we get called out for situations such as this that is narcotic related, but it is entirely possible that it could happen and that we may need to intervene. But remember, work your way up on your dosing for your Narcan for those patients, because all you're trying to do is just to get to improve their breathing, not to bring them back to complete consciousness. So there are many different types of toxic substances out there that we can inhale. The extent of the damage that they're going to cause our lungs is really based upon whether or not they're water soluble or not. So that's really going to impact that. So gases that are highly water soluble, like ammonia, will react to the moist mucous membranes in the upper airway, cause swelling and irritation. On the other hand, gases that are not water soluble can make their way deeper and lower into the airways and cause damage over time. They can even cause pulmonary edema, sometimes showing up as late as 24 hours later. A couple of examples of these are phosgene and nitrogen dioxide. So there's a lot of substances, that on the surface, seem like, oh, that would be terrible and this would be less terrible. It depends on, and if whether one affects the upper part of the airway or the lower part of the airway may seem more or less relevant. Believe me, if it's ammonia is going to have severe consequences to the upper airway. The swelling could be so severe that it would cause blistering in those areas, which obviously would be detrimental to someone's survival. Gases that are moderately water soluble will cause symptoms somewhere in between those two, somewhere between irritation and full-blown pulmonary edema. For example, mixing drain cleaner with chlorine bleach can create an irritant called chlorine gas, which is going to hit both the upper and lower airways. In industrial settings, they often use these kinds of chemicals in much higher quantities and concentrations than what we typically see at home. So be aware of the environment that you're going into. Make sure that it's safe for you anytime there's been an inhalation or any kind of chemical exposure of any kind, whether it's even at home or even in an industrial setting. The first thing you want to do is to get patients who've been exposed to these gases away from it right away, then provide 100% oxygen and assist their ventilations if necessary if they're having trouble breathing. If the patient is exposed to gases that are only slightly water soluble, they might not have trouble breathing until hours later, but they could develop acute shortness of breath after that incident. So keep that in mind. And these patients will most likely need to be transported to the hospital and monitored for a period of time before they're released and they're completely out of the woods. So make sure you know what substance is involved in this, and reach out to medical control or even poison control to make sure that the best course of treatment is being followed. All right, pulmonary edema. Pulmonary edema happens when fluid from the blood plasma, leaks into the lung tissue, which then causes a buildup of fluid in the lungs. This makes it harder for the lungs to exchange gases because it's really, really difficult for the lungs to exchange gases through a liquid. It is possible some of it will happen, but it's not much. It becomes very inefficient, and it can start affecting the patient before other obvious signs show up. So there'll be some subtle signs before things get really, really worse. So pulmonary edema is typically classified into two types. We have high pressure. This is often referred to as heart failure, and it happens due to issues with the right or left ventricle not working properly, maybe caused by chronic high blood pressure or other heart problems. And then the other classification is high permeability. This typically occurs with acute hypoxemia. It's caused by damage to the pulmonary capillaries from toxins or drugs in the bloodstream. So two categories of pulmonary edema. We typically see the high pressure one more often, but it is possible to see the other. There aren't many early signs to look for when it comes to pulmonary edema. By the time you start hearing fine crackles in the bases of the lungs, the fluid has already leaked into the capillaries, and it has increased the space between the capillaries and the alveoli. So it's created a barrier of sorts between the alveoli and the airspace, to where the gas exchange becomes less efficient, far less efficient. It has also caused the alveolar walls to swell, further leading to inefficiency in gas exchange. And then it's actually started to seep into the alveoli itself. So all kinds of problems start to happen. By the time we hear pulmonary edema, a lot of things have already happened. You want to listen to the lower lobes of the lungs by putting your stethoscope down there. On the back of the patient is almost always better. There's less tissue to listen through, and you can usually hear a little bit better. As the pulmonary edema gets worse, you might start to hear crackles higher up in the lungs. So as it progresses, they're getting fuller and fuller, so there's more and more fluid. It starts to work its way up. As it continues to worsen, the patient will likely begin coughing up a watery sputum that may even be a pinkish tinge because of the red blood cells that are contained in that fluid. The first step is to identify and treat the underlying cause of the pulmonary edema, then make sure to manage the airway properly and give oxygen to keep the patient's oxygen saturation levels where they need to be. Positive pressure ventilation can help by kind of stenting the airway, keeping it open and letting the alveoli reinflate, and reducing the preload and afterload of the heart. So this is positive pressure can be very helpful in our pulmonary edema patients. You can also use some nitrates. I talked about this in a little bit earlier in a previous lesson, where those nitrates are going to cause some vasodilation effects. It'll lower the afterload and help increase the stroke volume, which in turn will improve the cardiac output and hopefully allow some of that fluid to pull back off of the lungs. So, and along with that, with pulmonary edema, Lasix can kind of come into play in that, just all depending on the situation and what the underlying cause and what's causing that. Acute respiratory distress syndrome is a pretty rare thing. ARDS, as it's often referred to. It's pretty rare for us to see it out in the field. This typically happens when there's widespread damage to the alveoli, typically caused by shock or aspiration of gastric contents, maybe even pulmonary edema. Could be barotrauma from over-aggressive ventilations or from a diving incident or something like that, or a really, really hypoxic event where there's been some lung damage. We don't typically see this in the pre-hospital setting, because when it shows up in these patients that have experienced these things, they're typically in the hospital because they were in a pretty bad way to begin with. But it's not unheard of for EMS to wind up transporting somebody from one facility to another that is suffering from ARDS. This syndrome tends to be more severe when there's direct damage to the lungs, and because as it progresses, the alveoli become stiff and harder to ventilate. It becomes a lot more difficult. So it's not a good place to be. So the assessment process is pretty similar to any patient with a respiratory issue. Make sure to document things like oxygen saturation, breath sounds, or any sudden changes in their condition. Keep a close eye on ventilatory pressures to make sure you're not overventilating the patient in those patients that are on a ventilator. There are a few lung protective strategies to keep in mind, like using low tidal volume and an inverse inspiratory-expiratory ratio, so longer inspiratory, shorter expiratory, and allowing for a little bit of permissive hypercapnia. Okay, so next we'll talk about some problems that may not be directly related to the lung tissue itself, and maybe some of the surrounding structures or external forces, external causes, or the results of that. Anyway, so a pneumothorax, while yes, it generally has to do with there being damage or a hole in the lung, the problem becomes external to the lung, because what happens is air gets trapped between the visceral and parietal pleura and starts to take up that space, and it crowds out the lung. There are just inherent weak spots in the lungs called blebs, and these can rupture when they're under stress or pressure, which can lead to a pneumothorax. This stress could be something as simple as coughing, or even more severe, like aggressive bag mask ventilation. People with severe asthma or those who are really tall and thin are more likely to be at risk for this. Someone that is tall, thin, with asthma, it's not terribly uncommon for them to suffer at least one pneumothorax in their lifetime. When they're having an asthma attack and they're coughing, they blow a hole in one of those blebs and they start developing a pneumothorax, which is going to require treatment. Some may have a history of pneumothoraces in their past, but typically patients will experience sharp pain, especially after coughing, and then they'll start to develop increasing shortness of breath over the next few minutes or hours as that air continues to leak and fill that pleural space. It may not be as dramatic as a pneumothorax that's trauma related, but it can still have the same results. If untreated, it can progress in a bad way. Most patients with a pneumothorax won't need immediate intervention. They'll have some time. It's not, we don't need to, call the trauma team and, do all kinds of crazy things. But they do need treatment. They should still receive oxygen and be closely monitored for changes in their breathing. Some patients, believe it or not, are actually sent home with small pneumothoraxes for them to heal, for them to, as long as they're not actively leaking air. Now, if it's tension pneumothorax, that's a whole different story. It's essential that we act fast and we do, needle decompression to relieve that pressure and get them transported onto the hospital. So, that if there's any lung repair that needs to happen, they're able to get that lung back in shape to where it's working properly. Pleural effusion is a little bit different. It's basically, but it has to do with the same area. Pleural effusion is that sac of fluid that's, around the lung. And it's this forms and collects between the visceral and parietal pleura. Basically, we get an infection there. Oftentimes we get an infection, or there could be a tumor, or maybe even some trauma, and the lung begins to rub against each other. The tissues rub against each other in the lung and the wall of the chest, and it starts to get inflamed and fluid starts to build up. These pleural effusions, amazingly enough, can hold several liters of fluid. And a large effusion can dramatically reduce lung capacity, making it much, much harder for the patient to breathe. On top of that, they can be very, very painful and uncomfortable for the patient as they're developing and growing. It can become much more difficult to hear lung sounds because of all the fluid built up. And the patient's position can also play a big role in how well they can breathe. So as with many other breathing issues, the patient having a comfortable position that's comfortable for them to breathe is important as well. So always make sure that we're providing that for them. So changing the patient's position may actually make things worse. So Fowler's position setting up is usually the most comfortable position for them, as we can kind of see in this picture, if we can keep the fluid towards the bottom of the lung. You'll want to provide supportive care and monitor the patient closely until you can get them to the hospital. If it's a large effusion, that it may actually need to be drained at the hospital through a procedure called a thoracentesis. So they'll go in there and they'll put a chest tube in there and they'll drain that. And then they'll monitor, probably start them on some antibiotics and, treat for any kind of infection that may be going on in that. And it's going to be a few days in the hospital for that to ultimately be treated. Pulmonary embolisms. It's another one of those things that affects the lung, but it's not necessarily directly caused by the lung. It's not a direct lung issue. It's basically when the pulmonary circulation gets blocked by either a blood clot, a fatty embolism from a broken bone, maybe even amniotic fluid that leaked out during pregnancy or during childbirth. It even could be an air embolism that can happen, from a neck laceration or if an IV isn't flushed properly. A large embolism typically gets stuck in a major branch of the pulmonary artery is how this happens. This blocks the blood flow to that branch. And if the blood can't reach the alveoli, it won't be able to do its job and exchange the gases. The survivability of a pulmonary embolism has everything to do with how large the vessel is that it's blocking. The more lung that it blocks, the lower the survivability. So these are survivable, but they can be problematic. We also see pulmonary embolisms in sometimes in patients, in females that are taking birth control. It can be common with that because of the likelihood of the risk of creating blood clots. So it's not completely unusual occurrence. So pulmonary embolisms can be tricky because it doesn't always show up in a really clear-cut way. Early on, the patients might have normal breath sounds and decent air movement in the peripheries. The classic signs include sudden onset of shortness of breath, cyanosis, and possibly even sharp pain. One thing to keep in mind is cyanosis doesn't always improve with just oxygen therapy. So we've got clear lungs, they're gasping for air, very short of breath, they're cyanotic. We've put them on oxygen and it's not doing anything. So that would be an indication to kind of begin to raise a red flag. And then when we couple that with a history of what they have going on, maybe they've had a broken bone or something like that, or a major surgery, could be another indication of the likelihood that it's a pulmonary embolism. Pulmonary emboli usually start in large veins of the legs, where clots can form and then travel to the pulmonary circulation. So patients with thrombophlebitis or an inflammation of the veins with clot formations are at much higher risk of this, of course. Clots can also form, as I mentioned, with patients that are recovering from surgery, because typically these patients are immobile for long periods of time. And even people that are on a long flight, for several hours sitting in one position can be detrimental, where they can develop blood clots that can travel to the lungs and become a pulmonary embolism. For bedridden patients, doctors often prescribe some anticoagulants or even special stockings, and maybe even some other devices to help reduce the formation of blood clots in the legs. This is a little tricky to do, especially for patients that are post-op patients, because if they've been cut open, we generally don't prescribe anticoagulants to those patients because of the bleeding risks that may come along with those. So there's some other things that they'll do to try to stave off the possibility of an embolism forming. For patients with a history of deep vein thrombosis, a doctor may insert an inferior vena cava filter, an IVC filter. The filter works kind of like a mesh umbrella that opens up inside that vein, and then it catches any clots that are traveling from the legs to the main vein, returning to the heart, the blood supply back to the heart. Recent studies now actually kind of prefer the removable filters, which are designed to be taken out after treatment to avoid any risk of the filter eroding or breaking down or damaging the blood vessels in some way. These patients, I guess, after their surgery, they go in for their however many mile filter change or whatever. So they go back in and take that filter out. Now, a saddle embolus, this is a particular kind of embolus, and if you look at that picture, it's an exceptionally large pulmonary embolism that gets stuck at the point where the right and left pulmonary arteries split, and it can be immediately fatal. There's no fix for this. If it happens on the operating table, it's unlikely somebody would survive it. Very, very few patients actually survive cardiac arrest caused by such a large embolus. These patients often show what's called the CAPE cyanosis, which is deep cyanosis, that blue coloring of the face, neck, chest, and back, even with high quality CPR and ventilation. Similarly, what you would see in a traumatic asphyxia, we kind of see that the similar bluish color of everything, essentially from the waist up everything's blue, and that's a pretty good indication that they may have had one of these saddle emboli that's just completely blocked everything going to the lungs, and prevented it from getting through. So that is respiratory emergencies in a nutshell. All right, we will see you guys back at I think chapter 18, maybe 19, one of the two. All right, see ya.